now we will move to the second memorial lecture for the late Professor Muhammad Kamal al-Surugi. I will not talk about him. I will leave his student, Professor أشرف حاتم, which is now رئيس المجلس الأعلى للجامعات. He will address Professor Surugi properly. May I call for the chairpersons, Professor Ahmad al-Halfawi, Professor Asim al-Isawi, and Professor Walid al-Surugi.
بسم الله الرحمن الرحيم. يعني أنا مش هلاقي كلمات أعبر فيها يعني عن شكري وتقديري للدكتور السروجي إن أنا أكون أخد الكلمة إن أنا في جلسة زي ديت. أنا معرفتي بدكتور السروجي من قبل ما أدخل اسم الصدر ولصداقتي وأخوتي مع وليد. إحنا أخوات وأصحاب من زمن، وما دخلت اسم الشاست كان دكتور السروجي هو رئيس القسم وعلمني وليه فضل كبير جدا جدا عليا. فأحب إن احنا نرحب بالدكتور أشرف حاتم أستاذي ومعلمي، وهو برضو كذلك هو دكتور السروجي كانوا مشرفين عليا ماجستير ودكتوراه. ونسيب الكلمة لدكتور أشرف.
بسم الله الرحمن الرحيم. Our late Professor Surugi, he has two sons there. لكن I am his oldest يعني elderly son, and Professor Surugi was born in 1938, and he passed away in 2010, a few days before the last conference, which was held in Qasr Al-Aini in December 2010. He graduated from the Faculty of Medicine, Cairo University in '62, and then he proceeded to be the head of the chess department in 1996 till 1999. He took his doctorate degree in '72, and all through these years, Professor Surugi has his own school, and mainly it is in the pulmonary physiology and applied mainly pulmonary physiology, the pulmonary function test. And that's why when Dr. Tariq Safwat asked me to have a memorial lecture of Professor Surugi, we decided to have this lecture on the clinical implications of pulmonary functions. Professor Surugi not only has his school in pulmonary functions, but also he had a lot of things. He was interested, for example, in the medical treatment of hydatid disease, in schistosomiasis, and also he was one of the first people who was speaking about small versus large airways in asthma and COPD. Actually, this is a very big, he has a very big publications, and he has a lot of international and local awards. And Professor Surugi has a lot of students and friends. Many of them are present here today. Let us now speak about one of the very important things which Dr. Surugi has his interest, which is the pulmonary function testing in clinical practice. He used this not only in the Qasr Al-Aini Medical School, but also in his private practice also. We all know that the evaluation of human physiology dated from very early, but the pulmonary function tests and the use of it in clinical practice is not very well developed, like the ECG, for example, and the echocardiography for the cardiologist. We have a lot of categories for pulmonary functions tests. We have the airway function, we have the lung volumes and ventilation, we have the diffusing capacity test, we have the blood gases and gas exchange test, we have the cardiopulmonary exercise testing, and the metabolic measurements. The only thing which is used in clinical practice frequently is the spirometry and the flow volume loop. Some of the centers in the clinical practice and not in the faculties use sometimes lung volumes and diffusing capacity. In the ICU, most of us uses the blood gases. The cardiopulmonary exercise testing is used mainly by the cardiologist more than the pulmonary physicians, and very few of us use the metabolic measurements. Again, to use the pulmonary function test, we must know the normals or the norms, and the norms are predicted for age, height, sometimes body weight, and all pulmonary function measurements vary in healthy subjects, and this variability may range from 10 to 20%, and again we have a range of normality which is plus minus 20% from 100. If we come to the clinical application for the airway functions, we use spirometry, which is the most commonly used pulmonary functions, to detect the presence or absence of any lung disease, to quantify the extent of known disease on lung function, to measure the effects of occupational or environmental exposure, to determine the beneficial or the negativeness of effective therapy, and to assess risk for surgical procedures and preoperative procedures, and to evaluate if there is disability or impairment for any person. We have the old lung volumes and subdivisions, and we have the forced vital capacity maneuver, and we have the flow volume loop. All they are together are called spirometry. And the most represented part of the spirometry is the FEV1, or the forced expiratory volume, the first second, and the FEV1 over the FVC, because it is the standardized indices for obstructive impairment, and the forced vital capacity is that, and the slow and the static vital capacity is for the diffusion. As for the flow volume loop, the flow volume loop is a curve of graph of flow generated during forced vital capacity maneuver, and its clinical significance is mainly for the small airways, and if it's combined with the forced expiratory vital capacity, it can get obstruction, and we can see it, obstruction and restriction. We have these cartoons which shows the patterns of abnormalities of asthma, emphysema, restriction, either obstruction, upper airways, or variable obstruction. If we come to the peak expiratory flow rate by the peak expiratory flow meter, this is something which used in asthma, but again, the peak expiratory flow rate is an effort-dependent maneuver, and it is non-specific. So it is reduced in mainly every type of chest disease, but the daily monitoring and the morning and evening monitoring of the peak expiratory flow rate is good in patients with asthma, because it shows the variability, and it applies the zone system, or the road traffic system, which is green, yellow, and red zones. We have the maximum voluntary ventilation, which was used in the past by many clinicians in the setting of the pulmonary function labs, but its clinical significance is good as a preoperative maneuver, as it's markedly reduced. The reduction of it correlates with the postoperative risk for these patients having abdominal or thoracic surgery. the maximum inspiratory pressure and the maximum expiratory pressures is used, and it's mainly the maximum inspiratory pressure is used mainly in patients on mechanical ventilation for weaning, for weaning success and weaning failure. We have some specialized tests like the bronchodilator test. Every test for pulmonary function must be done pre and post bronchodilator if there is a sort of obstruction. And also the clinical significance, it shows the reversibility if it is more than 15% reversibility or 200 milliliters of either FEV1 or FVC, or it can be 30 to 35% increase if it is about the specific airway conductance, and the FEF 2575 for small airways, it is also 35% reduction, reversibility. About the bronchial challenge testing, and the bronchial challenge testing is a specific test to characterize airway hyperreactivity, and we may use challenge by, as we have seen in the last cases, by provocative agents, which like the methacholine, which we use on our laboratories here in Egypt. We can use also histamine. Hyperventilation with using cold saline or room temperature, it can be used, and exercise also, as we have seen in the last cases which was presented. Small airways are seen in the flow volume loop mainly, and it is and we can do a dynamic compliance or closing volume. The preoperative pulmonary function testing is very important for the patients, either any patient who is doing general surgery or any patients who are doing chest surgery, and there must be to estimate the postoperative lung function in candidates who are doing lobectomy or pneumonectomy, and to plan for perioperative care for those, including perioperative preparations for these patients, and maybe complications postoperative to minimize this, and to enhance the risk involvement of the surgical procedures, the morbidity and mortality from the history of these patients. It is indicated when any patient with a smoking history must do a spirometry before any surgical procedure. If any patient who has pulmonary disease, COPD, cough, sputum, or anything, any patient with abnormal physical examination findings, especially if there is abnormal breath sounds or ventilatory pattern. It's also indicated in any patient who is morbidly obese, or subject to an advanced age over the age of 60 or 70 years, subject to have current or recent respiratory infections or a history of respiratory infections, and any patient who is debilitated or malnourished. We use postoperative pulmonary functions to predict postoperative pulmonary complications. We either use spirometry post bronchodilators. We use sometimes blood gases. Exercise testing is important for those who are doing mainly chest surgery. And we sometimes use the perfusion, ventilation, lung scans to have the post-operative FEV1, which equals to the preoperative FEV1 multiplied by the percent perfusion of unaffected portions. We also have the pulmonary artery occlusion pressure test, which can be done before pneumonectomy or lobectomy. These are the preoperative pulmonary functions, and in this we can see the increased postoperative risk for these patients who have FVC less than 50% of predicted, FEV1 less than 2 liters or 50% of predicted, and FEF 25% less than 50% of predicted, or the VO max is from 15 to 20 ml. The high postoperative risk in these patients who is less than FVC is less than 1.5 liters, or FEV1 less than 1 liter. Candidates for pneumonectomy must have an FEV1 more than 2 liters per minute. The predicted postoperative FEV1 must be more than 0.8 if the patient has pneumonectomy, and the pulmonary artery occlusion must be less than 35 millimeter mercury. So these are some of the examples of pulmonary function testing or flow volume loop. Maybe the cartoons are not very good, but again, pulmonary functions in clinical practice is a part of the clinical practice, such as the X-ray and the CT, which we are using nowadays. Thank you very much for your attention.
Thank you, Professor Ashraf Hatem. And now calling for the AstraZeneca Symposium, calling the chairperson, Professor Tariq Safwat and Professor Nader Al-Fasih.